Good evening, everyone. Good evening. And welcome. I'm Tiffany Gilliard. I'm the Chief External Affairs Officer for Whitman-Walker Health. You're here with us this evening for an informative discussion on PrEP. We've got an exciting panel for you this evening, and we have an opportunity for questions and answers at the end of the evening. So if you would please hold your comments or questions until the end, we will definitely open it up for audience participation. Just a few housekeeping announcements before we get started. One, we will be live broadcasting this evening. So it is live on webcam. If you do ask a question, please understand that you will be live on webcam. And the power of social media means all of your friends all over will see you. Number two, this will live on our website. So if you are wanting to see this broadcasted again, or you want to share it with people after tonight, it will be available on the Whitman-Walker website. It will be on our YouTube, and it will also live on the Radio 1 website. Number three, there's a comment card you were given when you registered this evening. On that comment card, we welcome your feedback on tonight's forum. If you have any questions about this evening, or you have recommendations or suggestions on future topics, we will like to hear from you because we'd like to do these types of forums and town halls again in the future. So please feel free to give us your feedback on the comment card. You can leave it at the registration desk as you leave this evening. And I think that's about it. You can live tweet tonight at hashtag DC Prep Forum. That's hashtag DC Prep Forum. So without further ado, I will introduce Dr. Alan Greenberg with George Washington University Milken School of Public Health.
Thank you, Tiffany, and good evening. As Tiffany said, my name is Alan Greenberg. I'm professor and chair of the Department of Epidemiology and Biostatistics here at the Milken Institute School of Public Health at the George Washington University. And on behalf of the School of Public Health Dean Lynn Goldman, I'd like to wish you a warm welcome to our school and to this wonderful new facility here in Foggy Bottom. I also serve as director, many of you know me in this capacity, of the NIH-supported District of Columbia Developmental Center for AIDS Research. And on behalf of the academic HIV/AIDS research community of Washington, D.C., I'd also like to welcome you to this special event. Tonight, we are honored to host this unique forum sponsored by our colleagues at Whitman-Walker Health, who have provided such critical services to the HIV-infected and at-risk community for several decades. The focus of tonight's discussion will be on HIV pre-exposure prophylaxis, known as PrEP, which is a new tool in the HIV prevention armamentarium. We will begin the evening with a brief overview of PrEP by Dr. Rick Elion, who's the Director of Clinical Research at Whitman-Walker Health. We will then proceed with the presentation and perspectives on PrEP by Mr. Nick Gordine, a Whitman-Walker client. We will then continue with the panel discussion chaired by my friend and colleague, Ms. Tony Young, the Director of the Community Education Group, which, as many of you know, is an important community-based organization here in the district, who will in turn introduce the panelists. And we will conclude with questions from the audience from our panelists. Thank you for your presence this evening and for your interest in the topic of PrEP. We look forward to an enriching discussion of this important public health issue. Thank you, and with that, I'll turn it over to Dr. Elion.
Good evening, everybody. I'm grateful to be here and grateful to be invited and get a chance to have a conversation that we hope will bring out some of the issues around prevention for HIV. About 2 years ago, Hillary Clinton, and this is not a political endorsement, went to the Department of State to talk about the possibility as could we be on the brink of an AIDS-free generation. In other words, a group of people, when young people, old people, where no one would be at risk for HIV. If such a scenario could ever occur, and I hope that all of the panelists on tonight would be my colleagues in such a search for such a finding in the United States and in the world eventually, but first in the United States, the question is, what tools would we need to develop? And so clearly we're going to talk about different kinds of prevention. So I wanted to take about 5 or 6 minutes just to talk about some of the scientific evidence that there is about prevention. Very brief on some of the points, and then try and get into a discussion. We want this to be as fair and balanced a discussion about prevention. If people have different points of view, all points are welcome, and we open to that tonight. The first is I want to talk about just a model of prevention. The first is what you see here, which is PrEP, which is pre-exposure prophylaxis. That's what tonight's talk is about. And the idea is that this would be for HIV negative people who would take a medication or take some other kind of behavioral approach to prevent the exposure of HIV. And so there are advantages, challenges that we're going to get into later, and I won't dwell on those for now. But there is also post-exposure. We forgot to include the part about shutting your cell phones off before we start and about putting them on mute. I wish we had a clever way to do that, but you provided me such a wonderful opportunity. The second thing is post-exposure prophylaxis. So this is after a person has been exposed to HIV, they're concerned, and usually this is a shorter course than PrEP, upwards of about 28 days. This is something that is, we're doing it right now at Whitman-Walker, somewhere between 2 and 4 times a week, that individuals come in who've been exposed to HIV and wish to take a course of medication for a month. And finally, there's after infection, and this is an incredibly important and significant development that's occurred in the last, arguably over the last 20 years, but over the last 2 to 3 years really gotten more press, which is treatment as prevention, which is when we can offer treatment to more and more people. We can see declines in viral loads of individuals, and this translates into declines of viral loads in communities, which result in less infection from subsequent exposure because there's less virus in people when they're having unprotected contact. In the last 6 months, the issue around PrEP has taken more of a headline in public health circles. For the first time, both the CDC, the World Health Organization, and the International AIDS Society have issued recommendations and comments on PrEP, and so this has really put it into the light of both headlines in the New York Times as well as into people's conversations. Some of our colleagues will talk about that they think this is a good idea, and some will talk about this that they think it's a bad idea. And that's the point of having an open discussion so that we can explore that together. What you see here are the recommendations of who would be appropriate amongst the different committees. I won't go through them in greater detail. Currently, there is only, for the most part, one regimen that's been suggested, though potentially the use of just tenofovir alone, not tenofovir plus FTC. There are other regimens in development, and I'll save that for the very end. So it's not just about any product that one company makes. It's really about an approach to prevention, because we know that we're at the beginning of the development of products that are going to be used in prevention, and hopefully there'll be a number of these products available to promote effective prevention. The efficacy rates of these studies have been very variable. When we first talk about prevention, the first thing we always look at is using antiretroviral therapy for people who are already positive. And we know that for those people, when we get viral loads lower, the impact of prevention is upwards of 96% of how we're able to reduce transmission to HIV negative people. No one would argue that there's any better method of prevention than treating people who are positive, so that when they have unsafe or other behaviors or other exposures, they would not infect others. However, we also need there's also been a lot of work looking at other types of prevention strategies, and those have involved prevention for the HIV negative, which is where we get into PrEP instead of ART alone. And you see here a variety of studies showing very poor efficacy rates in these studies for FemPrEP, and also in Voices, where adherence was quite low, but very low, upwards into Partners PrEP, where you saw efficacy rates up to 73. And there's a range of efficacy. So it's hardly a silver bullet. It doesn't work all the time. It doesn't work for everybody. There's a range of efficacies. Adherence is one of the things that drives efficacy. This requires people taking a pill. It's prescribed once a day. There's studies, which I'll show you in a second, that show that if you take it 4 times a week, it probably works just about as well as 7 times a week. But adherence is critical. And so when you look at the studies, one of the things that have plagued these studies have been that people haven't taken the medications. Now, one of the interesting challenges that we'll get into tonight, I would imagine, is that there's a difference between open label studies and double-blind studies. The double-blind studies involve that people are taking a medicine that they don't know if it's active. They don't know if it's active. And so adherence often, when people don't know if they're taking the real thing, isn't as great as when it's an open label study, but not all the time. In the IPREX study, both IPREX and IPREX-Olay, where they had men who had sex with men from around the world, Latin America, Central America, United States, parts in Africa, adherence rates were not very high. And when they made it open label, the adherence rates continued to not be that high. So we know that it doesn't always work if it's an open label setting. In this particular study, when they looked at the Iprex-Olay data, they showed that amongst patients who took it 4 times a week, there was no infections present. So in patients who take this regimen, this is extraordinarily effective. And so I don't think we're going to get into a debate about whether if people take it, does it work? The question is, is it viable to have a regimen that people need to take at least 4 times a week? But in this particular study, they showed that a minimum of 4 tablets a week seemed to be efficacious. When you look and see in IPREX who was more likely to take their pills, one of the things they found was that people who were at higher risk were more likely to be adherent with the medications. And if you think about it, that makes sense. People who think they're at risk are more likely to take something to prevent risk for themselves. Those people who don't perceive themselves to be in as greatest risk were not seen. So people who were practicing non-condom receptive anal intercourse had a 1.69 or a 70% benefit of taking that. People who had more than 5 sexual partners, again, more than 60% benefit of efficacy. A known positive partner in a discordant relationship, 40%. It was not associated with age. Education was somewhat associated, but if you were had alcohol use more than 5 drinks a day on the drinking days, I hate to be near those people on some of their drinking days, cocaine use in the past 30 days and methamphetamine use, not associated with any particular strong association of significant value. So more related to people's behavior and if they perceive themselves to be at risk. We are just completing a project in DC that we have 3 sites, both in San Francisco, DC, and Miami, called the PrEP Demo Project. In this study, we enrolled about 700 men who have sex with men as well as transsexuals. And what we showed is that after about 12 weeks, we had 85% of our patients who were taking their medicines at least 4 days a week. This is an open label study, so people knew what they were getting when they took it. So there is a range of efficacy that we see. And this range of efficacy is due to a range of adherence, and that range of adherence is one of the operational issues about whether this is going to work. The final slide I have, 2 final slides. One final slide is a slide showing of the people who came into our study, 86% of them were already practicing unsafe sexual behaviors. Now, we talk about PrEP as if one of the things about PrEP is called risk compensation, that if you start taking PrEP and you feel you're protected, you're going to increase the amount of unsafe behaviors you're going to have. In our study, where 86% came in already practicing the behaviors we were trying to prevent, I'm not sure how we would show an increase in behaviors. And so the point is that in our study, people self-selected. People who came into the study were people who were already having an increased number of these kind of behaviors. Finally, the risk of, and so we'll get into, I'm sure, risk compensation, because I'm sure Michael's going to have some comments, and we'll go back and forth on that a little bit. And finally, on resistance. So one of the concerns about taking a HIV medication for the development of resistance is, would people be at risk for developing resistance if they take a pill that's used to treat HIV when they're HIV negative? And the real risk occurs if a person who starts taking the pill either is HIV positive when they start taking the medication, so we don't find that out right away. So they start on a subtherapeutic regimen, in other words, a 2-drug regimen, two-drug regimen instead of a 3-drug regimen, or they're taking it, they stop taking it, they get infected, they go back on, and now, again, they're HIV positive and they're taking this medication. The fact is that in 3 different studies, when you look at the development of resistance, there was very little that was seen. It will happen. There will be people who develop resistance while taking PrEP. I think it's unavoidable that that's going to be a cost of the action. The question is that an acceptable cost when you look at it in a cost-benefit relationship? I wanted to keep my comments as brief as possible because we want there to be as much discussion and balance between all the discussions. I hope these remarks were fairly objective and not biased in any way. And I thank you all for your time.
You've heard some of the scientific data, and we'd like to give you an opportunity to hear from one of our patients, Mr. Nick Gordine, a Whitman-Walker Health client.
Thank you. You can clap. Hey. Thank you. It's good to see a familiar face. So I've talked before but never in this capacity. So seeing a great familiar face helps me a lot. 3 years ago, I was confused. I was bitter. I was angry. Probably most of all, I was fearful. So I thought, how in the world could this happen to me? I mean, when I was in high school, I was on the AIDS Center of Queens County as a peer educator, going around the streets in New York, passing out condoms in exchange for some questions answered about how you can stop HIV. Because my counselor told me that you don't have to be infected with the disease to be affected by the disease. So 3 years later, 3 years ago, I questioned, how could this happen to me? I was educated, smart. I thought I made smart decisions, even through college. There was a couple of times where I had some pregnancy tests to deal with, but overall, I thought I was okay. So how could this happen to me? Bitter, confused, and full of fear because I had been betrayed. I had been exposed to HIV, unbeknownst to me. So I went in for this test, heart beating, sweating profusely, and I waited some time. And finally, I got the call to come in and sigh of relief. I'm HIV negative. Don't know how it happened, but I am HIV negative. So I went through PrEP after being exposed and realized that some habits are hard to break. And I realized that I can either continue down this same path of playing Russian roulette with my life, or I can make some other decisions and follow up with what my doctor, Lindsay, recommended. Shared with me about this study that's keeping people who've been exposed to HIV negative. Standing at the crossroad, I thought either I can be private and do my own thing and perhaps be okay, or I could humble myself and make better life decisions. And 3 years later, I stand to you today, still HIV negative because of PrEP. That's why we're here today. I'm extremely appreciative for the person I've become, not just as a result of me staying HIV negative and life choices that I've made, health choices, but also behavior choices, as a result of some hard-hitting, uncomfortable questions by my friend Anna. I made some life choices, and today, whereas I was confused, I'm pretty clear that people are living with HIV, and those who've been exposed are continuing to stay negative. I'm no longer bitter, but I've become better. Because not only am I become better health-wise, but also on an internal, emotional-wise, by dealing with the hard work. And most of all, I'm no longer fearful, but I believe that we're fighting forward through faith, through education, that people are living and existing and continue to stay negative. Fighting forward through education and teaching people that there's another way, another method of protection. Changing and shifting the dialogue to let people know that coupled with safe practices, PrEP is helping to save lives. And above all, I'm fighting and forging forward in faith because I believe like dialogues like this, we together are helping to pave the way to help to end HIV. Thank you.
Good evening, everyone. I want to thank you all for coming out. Particularly, I'd like to thank Whitman-Walker Health, the George Washington University, the panelists, but I especially want to thank you. You know, sometimes it's hard to have a conversation about a topic that we don't all agree on. But most importantly, I want to thank our panelists who I've known either directly or worked with directly over more than 20 years working in HIV and AIDS. We don't all necessarily agree, but I can say that the four people that sit before you have an unwavering commitment to ending the HIV/AIDS epidemic. And for that, I want you to give them all a round of applause before we start. And so with that, the first person I'll introduce is Michael Weinstein, who's the president of the AIDS Healthcare Foundation. Next to him is Dr. Rick Elion, who's the Director of Research at Whitman-Walker Health. Next to him is Chauncey Christopher Watson, who's a Clinical Research Site Director here at George Washington University's Milken School of Public Health. That's a mouthful. And next to him is my good friend, and I think probably now 25 to 30 years, Dazon Dixon Diallo, who is the founder and CEO of SisterLove in Atlanta, Georgia. During the next hour, we're going to have a thought-provoking, I hope, conversation. And I introduce them as colleagues, but I also want you to think of them as thought leaders. Very rarely, I think, in the work that we do we get the opportunity to have dialogue and to have people that kind of challenge how we think, how we see something, how we've experienced something. And maybe each and every one of them don't agree, but they will give us a perspective. And I think that we should respect their perspectives. And therefore, I'm asking that we all respect each other's opportunity to speak and share our views and our vision. With that, I'm going to say that we're going to try and keep this going pretty rapidly. We're going to try and do it in short spurts with 1 minute to 2 minutes worth of response. At 2 minutes, I might jump in and say, okay, that's enough already. I think actually, Rick kind of hit on it in the beginning, but I want to start with the most simplest, most basic question about PrEP, right? If a person takes PrEP when they're supposed to take it, meaning taking the regimen when they're supposed to, as it's prescribed, do you think that this will reduce their chance of becoming HIV infected to 0? Start with you, Michael.
0 is a absolute term, and I don't think any of us would agree with 0. I mean, I think that there's no question about the fact that people who have a blood level of Truvada in their system, a high blood level, will not become infected.
I hope we agree the whole night like that, Michael. I have nothing to add to that.
See, start off good, I say.
This is like, do you want to be a millionaire? They start out with the easy question.
Tell me what it's like to be a millionaire.
Easy, easy, easy.
It was a joke. It was a joke.
Well, all right then. I do agree, and surprisingly, I have nothing additional to add to that point other than I do think that 0 is an absolute number in which one does strive for, but we understand that only leads to abstinence to what allows us to get to 0. So as far as PrEP, it's hopeful that we will get close to 0 as possible.
Ditto. No, I'm with a plus. I mean, I concur with all of that, but I do believe that because sex and sexual behavior and sexual expression is fluid, there will be times when a person can pretty much count on 0 when they're not having sex, even when they're taking PrEP. When they're taking PrEP and using condoms, there are different ways that they actually can be confident that they're pretty much at 0 or at least at 0.0000 something. So yeah, I don't think it's fully 0, but I do think that there will be people who can be pretty darn confident that they're as close to 0 as we can get and still enjoy sex.
One of the interesting findings in IPREX-Olay was that people started to also change their behaviors. That people who were able to be adherent to PrEP also were having less unsafe behaviors and had higher, to some degree, even increased their condom use. I think there's always a dichotomy that we look at with PrEP and condom use. And I think that there's also something about engagement. And engagement when people are involved in clinical trials or in clinical work, and they tend to be a little bit more responsible about their behaviors. And I think that to some degree, what we're trying to evaluate with PrEP is not just a pill, but about if engagement with providers and with healthcare lead to better behaviors. And I think
I have to disagree with that.
Okay.
If I can.
Okay, I'm going to give you 30 seconds to disagree, and then I'm coming back with a second question.
Well, excuse me, I'm recuperating here. In IPREX, 93% of the people said they were taking the pills when only 51% of them were taking it. Self-reporting is notoriously unreliable. And beyond that, the type of engagement that you're talking about, which existed in these trials where people were paid, they were seen monthly, they were tested monthly, and they were intensively counseled, is not going to happen in the real world.
So I think actually that is a part of my next question. And a bit of that is, so what are the risks and benefits of PrEP to both individuals and community? Because if you have PrEP, I hear what you're saying, Michael, PrEP in a controlled environment is different than in a real world environment. So now I'm going to start with Dazon and come this way. So what are the risks and benefits of PrEP in community real live?
This is a question that I really combined with the original one, which was more about the useful tool and how we get there. And first, I would say that this is why, at least for the group that I work with, the U.S. Women in PrEP Working Group, we're fighting to make sure that there are more studies in the real world, that there's more implementation science that's going into the post-PrEP approval era that we're in. But I want to also locate, and I know this is going to come later as a different kind of question, but I also think that while we're debating the science that's been published and that is ongoing, I also don't want us to leave out the fact that there are many social and cultural reasons for why any number of prevention options that can be made available to anyone who needs them at any given time is what we struggle for. And PrEP is just one of those things. So there's some of those risks. We're still concerned about what level of side effects and where we weigh out the risk benefit from side effects versus the preventive, protective factors that PrEP offers people who will take it every day in its current form. That the issue and the burden of the testing is a concern, that people have to get tested on a very routine basis. And that, as you heard, the description of just that waiting moment every 3 months might be somewhat of a challenge, but the benefit of knowing that what you're doing every day is actually keeping that result where you want it to be, I think may outweigh for other people. And then just on the last, the whole issue around not having to disclose to anyone your own concern for yourself and your protection is a huge benefit. And for some people, not having to talk about what I want in sex and how I get it, and that has to be kept between me and my provider, and that's where I can keep it, I think may be benefit enough for people to outweigh the risk.
I agree with Dazon. I love that we're starting to have sort of this larger conversation of what is PrEP and sort of looking and examining the risk versus benefit for an individual. Personally, I wake up every day to come to work to save one life. And if PrEP can save one life, then it's extremely beneficial for me. And then it's really sort of this, and Nick really hit it, understanding we're giving additional tools and additional options for individuals to make their own decisions and choices. And I think as healthcare practitioners, it's relatively unethical and rude of us to be in a space where we're demonizing sex, which we're all products of sexual activities, let's be very clear. And sort of going forward from that, if we continue to demonize sex and not lift it up in a positive aspect, we are continually perpetuating the system that individuals can't have a conversation, they can't sort of be empowered to look after their own health care. And we're expecting sort of this whole synonymous activity of being positive versus being gay and enjoying sexual activities. I think really the other piece to this that I really want to highlight, and you hit on it, which was structural, but we have a broken healthcare system. So if we start to look at PrEP and this whole conversation of translating PrEP from clinical trials to real world application, we have to really begin to examine how is the healthcare system set up for us to be able to do that? Is it effective even in the wake of Affordable Care Act? We're dealing with populations that oftentimes do not interact with the healthcare system at all. So how are we sort of helping them move forward and providing cultural competent care where I actually have to have a conversation with a provider who may or may not have ever had a conversation about anal sex or rimming or any of that nature with the individual? How do you then change the healthcare system delivery more so than providing another option for them to protect themselves against HIV and AIDS?
And I'm sorry, just to lay one more topic on the table, which could be a whole nother conversation, is that the more prevention tools we have, the closer we get to ending criminalization of people living with HIV. I'm real clear about that.
So in my mind, the challenge of PrEP, which is one of the risks, is that it's a harm reduction strategy for sex. We've never had a harm reduction strategy for sex. Well, I guess we have. We call it condom use, but condom use is not used universally. We showed 86% of the people coming into our study didn't have condom use. And I want to make a distinction relative to a comment you made, Michael, which is the difference between IPREX and other open label studies. A study that's a closed label study that has a double-blind arm that occurs in multiple countries is always going to have a very different outcome than a study looking at what the results are here in the United States. What we're talking about today is PrEP in the United States. We're doing a demo project, which is an implementation study, which is what you're referring to, which is looking at what happens in the United States, not in the United States right now, but Miami, San Francisco, and DC is a surrogate for that. And we're not finding the same findings of 93% versus 51. We're finding 84% adherence. So to me, the biggest risk is that we would say that we understand how to prevent HIV, because we got 55,000 new cases for the last 7 years running. And we've got to be open to a variety of approaches. PrEP is one of the variety. It's a tool in the toolbox. It's not the only tool. It's a tool in the toolbox. The biggest risk to me is thinking that we have it fixed already, that it's done. We think there's going to be other regimens outside of Truvada that might be much more effective for PrEP. There might be ways to nest that in other programs that'll be more important the way than what we're doing. And I think we're at the beginning of the science. And I think when we're learning a new technology, we have to be very careful about overstating and understating what the capacity is.
I hope you'll forgive me if I take longer.
I'm gonna give you 2 minutes.
Well, I think this is lopsided.
Okay.
Okay. First of all, I'll start with the fact, and I expressed those concerns prior to this, and that it was 3-1. But let me say this: before I received this, I had agreed to do this talk, and so I thought the idea of a dialogue was important. But I was concerned when I saw this. Most of you have seen this. Well, I don't think Dr. Elion would actually, or I hope anyone would think that PrEP, under any circumstances, is going to be the end of HIV. Okay. I mean, we have 1.2 million people in the United States who are HIV positive. More than 800,000 of them have their virus out of control. If we want to talk about the most effective means of controlling HIV, it's bringing people to a level of undetectability. So I think we can agree on that. But my position and the position of AHF on this issue is based on the data that these trials have not been successful. So in relationship to what Dr. Elion said, so he brought up the issue of the, and your data may be more recent than mine since you're working on the study, but the information that I have is that on the adherence, that after 4 weeks, daily adherence was 66% in San Francisco, 45% in Miami, and 19% in DC. And that after 4 weeks, the adherence was 4 doses per week adherence was 54% in San Francisco, 45% in Miami, and 26% in DC. And then in IPREX itself, first of all, about a quarter of the people excluded themselves from the open label, said they weren't interested either because of side effects, inconvenience, or preference for other prevention methods. Okay, so out of the 1,225 people remaining, 5% took it daily. 5% took it daily. 22% took it 4 to 6 times a week. 12% took it 2 to 3 times a week. 27% took it less than 2 times a week. and 26% did not take it at all. And when we talk about another tool in the toolbox, that's fine. And if it didn't rely on daily adherence, I'd be for it. If there was a shot every 3 months, I'd be celebrating with everyone else. I'd still be concerned about syphilis and chlamydia and gonorrhea and all the other things we have to deal with, but I would be celebrating that. But, you know, when we talk about, you know, being, what's ethical, I mean, we have worked for more than 30 years to create a condom culture in the gay community. And I'm referring now specifically to gay men. And according to the CDC studies and according to our own study done by a third party, more than 60% of gay men used a condom in their last sexual encounter. So you can, and those were done anonymously. So obviously, when you're talking about a study like the one they're talking about at Whitman-Walker, yes, there's a high-risk population that never uses condoms. We understand that. But the first ethical responsibility in medicine is to do no harm. And if we destroy the condom culture, then we have done really a terrible disservice. And let me just say that we've been fighting this battle in the gay community since day one. It was documented, it was documented in The Band Played On. It was documented in A Normal Heart. And when we didn't heed the advice, it always ended badly.
Michael, so I think that what I'd like to do is, I hear you with where you see the results and the impact of the two studies, right? You said the DC, San Francisco, that study, and then the IPREC study, right?
Right.
But one of the things that you kind of closed with was that we have developed this condom culture, particularly amongst men who have sex with men. And that's a part of, I think, what I want to kind of talk about with the kind of the second part of my question, which is that the role of PrEP is not just in isolation within the MSM population. We have a huge impact within communities of color. We have a huge impact in communities of women. So while the condom culture was developed and kind of reinforced within an MSM community, one of the things, and some people say, I'm not saying I say it or I believe it or I think it, but some people believe that PrEP might be a tool for other communities to engage in biomedical prevention in a new way, right? I don't challenge your data, I'm not challenging that. What I'm gonna do is I'm gonna start with Chauncey with that, because I know you work a lot with Black MSMs, but I think you also work with other communities. And I think that that's the second part of the question for folks is, what's the role of PrEP in these other communities? What's the role? How do we get PrEP in? How do we get PrEP education into these communities? How do we talk about PrEP when, I mean, if you look at the audience even, it's not really reflective of the district. So how do we begin to have this dialogue and nothing personal, y'all. It's just fact, not fiction, right? I mean, it might be DC in about 5 more years, but not right now. But that's the other part of my question with regard to communities.
Right. So
Sorry about that.
Gotta love Tony. So I love where this question is going. I do appreciate it. And so I'll start with sort of this personal piece where when PrEP first came to the scene, I was anti-PrEP, and I'll be the first to say that. Did not believe in PrEP, did not think it was gonna work. If research was coming down our pipeline, I would be like, absolutely not, we shouldn't do it. But then it was sort of, I had to step out and realize that because it wouldn't work for me, because it was not something I would personally take, I was then sort of providing a knowledge deficit or some type of risk to a subset of individuals who would potentially be beneficial to PrEP. So it was really a responsibility owed to myself to really understand the nuances of PrEP and to really dive in if I'm going to really consider myself a person who's trying to end the epidemic among communities, especially communities of color. So we started to really look at it, we examined the data, and what I really saw was that, you know, I take blood pressure pills, I don't take it every day. In fact, it was some months that I didn't take it for like 6 months at a time. But it was really understanding my own personal struggle that I realized that people are not using condoms. Let's be very clear. So for us to sit here and anticipate or sort of assume that condom use is happening in this community, it's not. And if that was the case, we wouldn't be seeing the rates of infections that we are seeing, especially among Black men who have sex with men under the age of 30. So it's really time for us to sort of step outside of ourselves and realize we have an additional tool that could potentially work, not for every single individual that's having sex, but for a subset of people. And what does this subset of individuals look like? And how can we make it effective for them to really adhere to the medication? Second, I think it's really critical for us to sort of understand, you talked about this condom culture. And I think you said about more than 60% use condoms. That rate really goes up in the African-American community. We have literature that supports that Black MSM are not getting infected because of their actions and sort of their risk behaviors, but because the community viral load is there. So we do agree on one point that it's important for us to drive down community viral load. Unfortunately, we're not here to talk about treatment as prevention. We're here to talk about how to prevent individuals who are negative from contracting the disease. And I think it's really critical and important for us to understand sort of this empowering piece that we like to talk about and sort of, oh, we're taking away the condom piece, we're taking away people from using condoms. But you're not taking away something that people aren't using. What we're doing is adding to something and saying it's important for you to lie down with who you want to lie down with. We're not going to judge you for that, but here's a tool that you can use maybe for 6 months, maybe for a year. But unfortunately, when you use that tool, the conversation we're not having is that you have to engage in a healthcare system at a different level than you're not doing now. If they were engaging in that level, we really wouldn't be having sort of this overall conversation. Community viral load would be down. Treatment as prevention would be extremely wonderful, and we'd be all in this utopian world, almost to zero for HIV infections. So I think we have to really begin to utilize and choose our words wisely, especially when we start talking about communities of color, which are not represented in any of the studies that you're talking about and don't have data for communities of color, because we have always been disempowered and disenfranchised for not participating in those studies. So until we get data of communities of color, we really can't talk about how this will end the epidemic, because the epidemic phase has really changed to Black in the domestic agenda.
Thank you, Chauncey.
So can I chime in on because this is.
No, Rick, we're going this way.
Oh, fine.
Rick.
I like to think we're all colleagues here. I don't know how you feel ganged up on, but since you seem to be...
Well, I think there's 3 people in favor and 1 person against, so I think that's usually considered a disproportion.
Well, and Michael, Michael, I want you to know that I'm acknowledging that, and that's why I'm giving you extra time when your turn comes around.
Thank you.
But let's make it interesting then. Let's talk about the condom culture. The condom culture that results in 1 in 7 people having chlamydia or gonorrhea coming into our clinic. The condom culture that allows 55,000. I know, and the condom culture that we measure in our community, both men of color and Caucasian men, is not a culture that men consistently use condoms. I am a parent, and I tell my kids to act responsibly all the time. As a doctor, I tell my patients that, but they don't listen. People don't listen to their doctor about what to do in the bedroom. Surprise, surprise. So I've learned that what I want to try and do are find things that are effective, not things that I'm going to try and convince them to do. And though I think condom use is an excellent idea, you and I would never disagree about that. I just think we need additional tools, because the condom culture, to some degree, 20 years into the epidemic, has failed us. It didn't work. And I know that we don't feel the same as that, but I just don't think we can say with 55,000 new infections and 14% of people coming in with STDs that a condom culture qualifies as a culture.
Well, let me start with the first thing that you asked about women. When I testified before the FDA against approval of PrEP as a public health intervention. The thing that shocked me the most with the decision was that it was expanded beyond men who have sex with men to women. Let's just be clear. Let's go back to the data. The 2 studies that were done on women were shut down because they had no benefit. That's the data that we've collected, all of it in Africa. There were 2 studies with partners that showed some pretty good numbers, but they were based on people who had been in long-term relationships who came in together. So that's a very, very specialized group. If nobody used condoms, there are about 600,000 people, men who have sex with men who are HIV positive in the United States. They're responsible for about half of all the new infections. That means that they are responsible for approximately 25,000 new infections. The rest come from people who are positive and don't know it, okay? That means that actually only a very small percentage are passing the virus on a given basis. And that could be because they're undetectable, but most of them aren't. So I just want to say, we can argue it as much as we like. I categorically reject the idea that nobody uses condoms, and that we don't have a condom culture. Condoms have not failed. You know, in public health, it's always a harm reduction model. Okay, one of the things that kills people in hospitals is that people don't wash their hands. Okay, and it's never going to be perfect. But if we didn't remind people to wash their hands, more people would die. So it's a never-ending battle, but we can't give up on it. But one thing I want to say, we'll have time for other questions here. We'll debate other issues, but let's also be clear. There have been according to the Department of Public Health in San Francisco, there have been 3,000 prescriptions written for PrEP in the United States outside of a study environment. 3,000. That's not even a spit in the bucket. And half of them have been among women. So there's about a grand total of about 1,500 MSM have been prescribed. That tells you something not only about the MSM community and what they want or don't want, but more than anything, it tells you about the medical profession and their lack of embrace of this strategy. You know, and some people have interviewed me and said, well, some people blame you for that. Well, I had no idea that I had that kind of influence over the entire medical profession in this country.
Thanks. Dazon?
So there's a lot in everything that's been said, and I have a couple of things. First, I just wanted to, I'm a little ticky about the data as well, and I wanted to point to a couple of things. Self-reporting, if we can agree, is unreliable, then it is not only unreliable in terms of people talking about how many pills they took, but it's also unreliable in people telling you how many condoms they use. I just want to be clear about that.
I agree.
The second thing is I appreciate the furor around the 2 women's studies that did not prove effective, that were shut down for futility. I will say that what we have learned in the ongoing study is a lot more about the need for behavioral and social science integration into clinical trials from the beginning, because we're learning a lot more about the women who were in those studies to start with, who were extremely adherent to the trial, just not to their drugs. The information about Partners PrEP is absolutely incorrect. What we do know is that for those women who were adherent to PrEP and for whom it was most successful, yes, they were older and they were in longer-term monogamous relationships for the most part. But for those who were less adherent and for whom it was less effective, they were younger, they were in less long-term relationships, and for many of them, they were in concurrent relationships. So let's not shadow the data for whatever our argument purposes are. I say put it all out there and let people decide. Where I come to, though, is I have been among a whole lot of women in the feminist health community and in the reproductive justice community, have been fighting for microbicides before gay men even thought about what a pill a day might mean, because the autonomy factor is real. Condom culture, I am a developer, a creator of an evidence-based intervention that is now included in the CDC's compendium. It's a behavioral intervention. It is around increasing condom use, reducing the number of partners, getting tested. It is effective in its frame, but it is not perfect, and it is not as effective even if these women were taking PrEP. So let me be really clear. Women do not have an autonomous tool in their hands that they can control to protect themselves, whether it's the condom or treatment as prevention. I want you all to hear this. For me, in the context of women having choices to protect themselves, treatment as prevention is amazing. It is what we're going to get to for people living with HIV in terms of their ability to not transmit, but to also live healthy and well. So it's about viral suppression. Treatment is another question. But that still puts not only the burden of prevention on one person in a given relationship, but it also says, for me, if I'm negative, I am just like waiting for someone to use a condom. I am waiting for someone to take their meds every day and become virally suppressed, which removes my power and my agency to protect myself. So whether PrEP is on a daily pill that works for me, or whether it comes in a ring or a film or in a long-acting injectable, or God bless us if there are any virologists and microbiologists in the house, I am so looking for the non-ARV-based microbicide in the dark chocolate. I'm just saying. So I would be so adherent, it would not be funny. So I just to close it out, I do not want us to take the debate and the science out of the context of what's happening in real people's lives and what we really need. And I will repeat it over and over. It is, we need the best, fastest science that brings us the most effective tools for whomever needs them when they need them. Point for now.
All right, so what I'm gonna do is I think we should do one more round on this, because I think that a bunch of points got made. So Rick, I'm gonna start with you.
I loved your comments. First of all, the number of new prescriptions is, we can debate about the number, but one thing we can't debate about is when men are offered this particular approach, not when doctors are asked to prescribe it, but when patients are asked if they'd like to do it, there's close to an 80% acceptance rate across 3 different studies. So the issue about the lack of kind of popularity of this, I think, has as much to do with the access issues and healthcare delivery, much more so than it does with PrEP. And I think we shouldn't confuse the implementation and utilization with the science. And the science is very clear. If people take these pills, it protects them. The question then is, how do we as a healthcare system find ways to do that? Now, do I think that you've been responsible, Michael, for keeping people from getting PrEP? Of course not. I don't think so. But do I think that ads that put crosses across PrEP in newspapers across the United States is conducive to a scientific discussion? No, I don't think that either. And I think it's great that you're here tonight, and I'm thrilled, and I want you to feel like you have an equal place at this table no matter how many people we have. But do I think a media campaign that says bad things about PrEP that's not all based on science is a good thing? And I don't think the ads are all based on science. I think that's a harmful thing. And it troubles me as an HIV advocate to see that kind of dealing with the implementation of how new studies get developed. You made a point about how in the women's studies that we know that the studies had to be terminated because the adherence was so poor. We shouldn't confuse that with efficacy. Right. The studies where women actually took the drugs, it was more efficacious for women than for MSM. Right. in most of the studies. And so I think we need to be very cautious about when we use science to talk about these things, because to go from open label to closed label studies and to talk about 2 studies but not include a third is selective use of science. And I don't think we want to do that.
Well, so I was waiting.
Okay.
Yeah. I was waiting how long into this we had to go before I got attacked personally. So the thing about this is that, first of all, in terms of whatever advertising or whatever messages have been put out there, it pales in comparison to the attacks and very personal and ugly ones that myself and AHF have experienced as a result of taking what we consider to be a principled stand. But
Can I just, I'm sorry, I just want to say one thing.
No.
Let him finish.
But I don't want you to feel attacked personally because your contributions to HIV have been significant. I want to clarify. I don't want you to ever feel attacked personally. I'm attacking an action that you took, not you personally.
Okay.
I'm very grateful for what you've done personally.
Well, let me just say this, okay? And I'm just quoting from a very well-researched and developed article that was published across the country. Intent to treat results are thought to better reflect outcomes in the real world. A drug may have, these are not my words, a drug may have strong antiviral potency, for example, but if people find it too inconvenient or too toxic to use regularly, its real effectiveness in practice may be low. And the last ad that we ran specifically and exclusively dealt with efficacy. I mean, it's interesting. I think that we've really tried to keep this exclusively on the science, and a lot of the, I mean, it's funny because how things get morphed. People came up with the phrase Truvada whores, and they got T-shirts. Okay, somehow in the mix of things, it was implied that I had said that, or that AHF had said that, or that it was derived from what we thought. So, things get crazy in this blogosphere world that we live in. But I want to just, I'll just end by saying, again, to be clear on what is official and what is not official. The FDA guidelines for the use of PrEP, what is approved for? Truvada for PrEP indication should only be used as part of a comprehensive prevention strategy, including consistent and correct use of condoms and risk reduction counseling. We've gone in this discussion, when we went to the FDA, everyone said, it's going to be condoms plus Truvada. Then we went to, it's going to be condoms, it's going to be Truvada without condoms. And now we've gone to 4 times a week. I can't tell you how dangerous talking about 4 times a week. That's cherry picking the data and extrapolating from it. Okay, are those 4 days after you've had unprotected sex? When you tell people 4 days, does that whittle down to 2 days? Okay, even if you're for this, we should not. It is incredibly irresponsible to talk about 4 times a week, in my opinion.
Sure.
I just, and I want to, first of all, echo Rick and say that nothing is, as far as I'm concerned, is being said an attack, but disagreement does not mean you're under attack. It means that you also then have to stand up for what you say. And that's what I think this whole conversation is about. The idea that at some point, just like with any intervention that has been developed up to now, will be adapted one way or another, whether it's at a community level, whether it's at a public level, or even when it's at an individual level. It is up to us to understand how far that adaptation can go and how far it cannot go. So I would say again that the studies that have been done to now are not the end all be all. There are many more years of us learning this. But if we don't even make it available to people, then how will we learn? That's the first thing. The second thing is, and I know I'm not confused, that we are talking about PrEP in the US, right? But I live in the southern US, which is a whole lot different. And we even have different data in terms of the ratio of infection rates among men and women in the South than we have in the rest of the country. We could say that we are beginning to look a little more akin to our brothers and sisters in sub-Saharan Africa and the Caribbean than we are to our brothers and sisters in San Francisco, Los Angeles, Chicago, and New York. And so given that, I do have to bring in the women of the African diaspora into this conversation. Women, and I talked to one of my South African compadres this morning, comrades, who said to us, what the FDA has said in the US, will go for us in South Africa. So even though they have to go through their regulatory process, people will take for that real fact, that gold standard, that if it's okay in the US, then it's going to be okay for us. And so what I think is really important to remind you is that more than half of this epidemic are in women. 2/3 of those women are in sub-Saharan Africa. And they're all concerned about pregnancy. They're concerned about serodiscordancy. They're concerned about gender imbalances and inequities in their relationships and in their communities. And so this is why they stepped up in the thousands to participate in those studies where the incidence actually lives. We had a webinar just last week on PrEPception, which is just a conversation on the role of PrEP in conception. More than 350 people came on that call to learn more. So when you start, again, parsing the data, it's not just here or there. It's not a zero-sum game. There are a whole lot of layers of consideration in here that don't all come out in some of the quotes from the data or the ads that you're using here. I'm going on what people's stories, their anecdotes, their lived experiences are, including people who have examined PrEP, who are in serodiscordancy, and who have made a different choice for themselves. I want that choice for them too, to say no. But you can't say you don't have anything to not even say no to. That's also a question for ethics.
So I will also say welcome, Michael, to the George Washington University School of Public Health and Health Services. Please don't feel that this is an attack in any shape, form, or fashion. We welcome you, and if you would like to take a tour of our beautiful building, I'd be more than happy to do that later.
I've spoken here before. Thank you.
Welcome again. So just to be clear, you're talking about sort of the whole conversation around men or individuals who don't know about PrEP. And I think if we examine data, which we love to do, and the literature which is out there, Kaiser just released some data which was very critical on Friday, which looked at about a quarter of individuals when asked about PrEP were not, it was only about a quarter of them who knew about PrEP. And so when you start to look at, here we are about 2.5 years later, and we still have done a very poor job as practitioners, as educators, as community advocates, to really take what we know to be true about PrEP, whether it's we agree with it or not agree with it, but disseminate that information in an unbiased, unethical, a very ethical, unbiased way to communities and allow them and empower them to make their own decision. We've not done a very good job. Also, what was included in that data was that when asked, should PrEP be available, over half of the respondents said yes. So again, I go back to really stating it's really critical for us to, as we're starting to talk about self-report, translating this into community science, what is that system going to look like? This is a structural issue. It's less about behavioral, but it's really structural. And are we a deficit, or are we an addition to that whole conversation? Are we providing our patients with every single possible option that they can have? Telling them when you take PrEP, you should still use condoms. But let's be very clear, you may not use condoms, and I'm not going to judge you for that. But here's a tool that you can use that may be beneficial for you for X amount of time. And we still have additional information to learn. I think that's okay to say that. It's setting the expectation, which goes back to not doing any harm, which is the first step of medical care, as you stated before. But it's also taking it a step further with giving them the full entire picture, allowing them to make a decision based off of themselves.
So thanks. What I'm going to do is I'm going to ask one final question, and I'm going to open the question up for you, the audience. So if you could line up there are 2 mics in the room. If you have a question, you could line up at either mic. Remember that this is being live webcasted. And so the first thing I'm going to ask you to do is say your name, then your question. So my last question, and this will make everybody kind of go crazy, but it's what's the role of PrEP, right? And other biomedical interventions in helping us achieve the goals of the National HIV/AIDS Strategy. We're supposed to report out in 2015. What's the role of PrEP and other biomedical interventions in achieving that goal? Mike.
Well, that presupposes that you think we have a national AIDS strategy.
I opened that back can of worms.
Okay. Okay. So.
There I go. Right?
Okay. I want to say that I really wholeheartedly agree that the situation in parts of the southern U.S. Resembles sub-Saharan Africa. I mean, AIDS Healthcare Foundation treats 351,000 patients in 36 countries. We're in 13 states. We're in 11 countries in Africa. We have more than 150,000 patients there. And what weighs on my mind, my conscience every day is that there are 4,500 AIDS deaths every day in the world today. AIDS is not over. And I hate these slogans about, I don't like AIDS-free generation. I don't know what it means. No one's going to be born with it. No one's going to get it. Who's in the younger generation? I don't know. And I don't like getting to zero. I don't know what that means. I don't know what, I mean, I can go down a list of these things. The final chapter in AIDS, I don't see it. Until we have a cure or a vaccine, it ain't happening. And so let's stop talking about it because that's going to discourage donors, et cetera. 23 million people in the world do not have access to ARVs today. So I don't think that the United States is making a serious coordinated effort to improve sexual health or to control HIV. I think that the President of the United States has not been a good friend to the issue, either internationally or domestically, which has been shocking to me as a very early Obama supporter. But, HIV prevention hasn't failed. It's never been tried in a serious way in this country. And in countries in which it was tried in a serious way, for example, in Northern Europe, it's been very successful. So I think if we really want to have a serious conversation about controlling HIV in this country, we have to have 5 times more access points, particularly in the Deep South. I mean, we're in Fort Worth, Dallas, Baton Rouge, all these places, and there's nobody else there. Okay, we got to get serious about making testing available in emergency rooms, in every STD clinic, et cetera. And there's so many things we haven't done that we should be doing.
Can you repeat the question?
The question was, okay, hypothetically, if there is a national AIDS strategy, what's the role of PrEP and other biomedical interventions in achieving the goals? We have a report out due in 2015. That's why I'm asking. And this is another tool, as we've said today, in the toolbox. What's its role in achieving the goals of the national AIDS strategy?
I got back from Uganda about 2 weeks ago. In Uganda, there's a higher percentage of people on HIV medications than in the United States. That's crazy, right?
Yeah.
A national strategy. Well, it's hard to. It's difficult to do a national strategy in our country for a lot of reasons. That being said, with a higher number of cases of people on ARVs, albeit maybe not always the best ARVs, and with you've got 160,000 new cases. You can't treat your way out of the epidemic. There's no way by using treatment as prevention, no matter what we want, because of all the difficulties of accessing care, that treatment is going to be enough to get us out of the hole we're in. We need to find prevention strategies. Is PrEP perfect? No. Truvada is the first medicine used for PrEP. We're testing another regimen made by another company that's an injection that you can do every 3 months. That might be even better. We're going to be looking for other alternatives that we can look at. The point is, we're trying to say that biomedical interventions are not about Truvada. They're only about Truvada in 2014. They're about medicines they're going to be developing over the next 3 to 5 to 10 years. And hopefully we need to find ways to make up for what is human behavior and the deficiencies of human behavior. I want to live in an empathic world that lives with diversity and plurality. And my vision of a world that deals with diversity and plurality has a kaleidoscope, to use the expression, a rainbow spectrum of approaches. And I think until we commit to a broad approach, including prevention, including treatment, including PrEP, and optimizing PrEP, we're not going to get to the point that we can talk about an AIDS-free generation.
Biomedical preventions alone will not get us to zero AIDS-free generation, whatever makes you, the word that we can feel and all agree upon that makes us very comfortable. Alone, no, it will not get us there, but it is a huge, giant leap that we did not have before. I was recently in a conversation and someone from North Carolina asked me a question, and it was very critical that she said, if we had this drug or if we had PrEP in 1989 or 1990, would we be still having the same conversation? And it really resonated because it not being and being extremely understanding my privilege of being young on the panel and being a part of the sort of latter part of the epidemic, I can't necessarily say we would not be different or if our response would be the same, that we have something that potentially could work for a subset of people. Now our job is to figure out how does this now work for those subset of individuals and provide options. I dream of a world where we have a menu approach. So it's an individualized approach to ending the epidemic. A person comes, they say, I'm positive, I'm negative, this is what I do sexually. Can you do to either treat me or prevent me from getting the disease? That is what will allow us to make an impact in the disease and the epidemic among especially communities of color. But in order for that to happen, especially when we're talking about the strategy, I think it's really important for us to acknowledge that this is the first sitting president that has ever said the word out of his mouth, Black MSM. And acknowledge that around the rates of the HIV infections among this cohort of individuals. So to sort of say there's no support, I think we have to be cautious of that, but also move that to an advocacy standpoint and say, well, what additional support are we looking for? How else can he or the administration support us fully and holistically? As it relates to the National HIV/AIDS Strategy, which may or may not exist, I think it's really important for us to look at sort of the key markers and sort of understanding before PrEP, how would we have maybe hit those markers or not hit those markers? And now that we have PrEP and this whole biomedical conversation, how has that enhanced us? And we can model that, we can look at statistics, and that sounds like a wonderful project for a student in here. But also further, we're having a conversation we've not had before, which is access to care. What does that look like? And how broke is our system of healthcare delivery as it relates to sexual reproductive health for all individuals, not just communities of color, but for every single individual, which is probably why we could look at women having the most scripts for Truvada, because they have a proven history of sexual reproductive health. So let's not say it doesn't work. Let's say, how can we make this effective and move forward with a new sort of model and menu approach?
Dazon?
So first, I want to be Rick's neighbor in his world. I agree. I don't conform to the AIDS-free generation, the end of HIV in its iteration. I do believe this is going to be over one day, and I'm just going to be in it till it is, whatever that over means. But what I do think is that, just in terms of the question around the strategy, is that we have a strategy because it's a strategic thought paper. What we don't have is the strong implementation needed to make that strategy work. That's the first thing. So we've still got, so when that report comes, first of all, I'm expecting a shadow report from those who don't agree with whatever report comes out. And the second thing is I guarantee you the grade is going to be incomplete. Because it's not finished. It's not finished with implementation. We will need a next strategy and a next strategy and a next strategy until it actually is over. But I would like for folks to acknowledge that if in that next iteration, we do see a reduction in the incidence, then credit it for the work that's been done since that time of that strategy has come out. When we see an increase in people accessing treatment and care, credit the work that's been done since we knew we had a strategy. And when we see a reduction in health disparities, especially what Chauncey was talking about in terms of access and engagement in health, when we do see a reduction in health disparities, including stigma, sexual stigma, not just HIV, then credit the work that's been done because somebody somewhere said, we've got some aims, now let's work towards them.
Thanks. So our mic's filled up very quickly, so we're gonna set some ground rules. No speeches, questions, and if you have it to a person, let me know. Give me your name, the question, and then we're gonna go. Name, question, and go.
My name is Terry Michael. I'm a 40-year member of the Washington gay community. I approach this as an investigative reporter. And my question goes probably to the only clinician on the panel, and others can comment. And that's the serious adverse effects long-term of nucleoside reverse transcriptase inhibitors such as Truvada. I haven't seen Whitman-Walker or anybody say, how long can you use this stuff? A year, 2 years, 3 years, 5 years, 10 years? And secondly, if I had gone to my doctor when I was 28, when I got here in 1975, and said, Rick, give me a daily prescription of antibiotics because I'm going to the baths a lot and I want to ward off pre-exposure prophylaxis to gonorrhea, would he not be engaged in medical malpractice to give me that? And why is this not malpractice?
Thanks. Rick.
2 questions. One, toxicity. First of all, every medicine has a toxicity. Truvada has been associated with issues with renal dysfunction and bone loss. You see it in about 6 to 7% of patients who are on it for more than 2 to 3 years in clinical trials. You could argue that upwards of maybe up to 10%. It's a known side effect. It's a problem of the medication. So it's a reason that nobody should take this without understanding the risks and benefits. It definitely has a toxicity, and it's one that we think is manageable. If you find it, you can stop it. Usually it's reversible in the sense of being in this. Is it an acceptable risk? Well, no toxicity is acceptable except in the eyes of the person taking it. They've got to make their own risk-benefit decision. In terms of whether we would have recommended antibiotics for prophylaxing for gonorrhea back in the 70s, there was no data to support it. In fact, there was data to show that there was excess amounts of resistance if you did that, and that it was not efficacious. The data on Truvada is different in terms of resistance. It's not the same as with antibiotics. And so we can talk about it as a preventive medicine in a different light than we can as an antibiotic.
How long can you take this?
In terms of how long you can take it, the best data I have is on patients who are HIV positive who've been taking it for long periods of time, long periods being up to 10 years. And those patients, the incidence I told you of side effects of about 7 to 10% would be accurate.
Okay, thanks. Ron.
Thank you. My name is Ron Swanda. I have a observation, and it goes with a question. You put up some data that indicated with 4 days of Truvada dosage might give you protection. I want to see if I perceive that correctly. And the second part is, why don't we ever hear about post-exposure prophylaxis, use of Truvada for that? If you think you got exposed, why don't you start taking Truvada and use it as a post-exposure prophylaxis?
Number one, I think Michael's point actually highlighted this. I'm not advocating that people take Truvada 4 days a week for protection. What I was showing was data that showed that people who took a minimum of 4 days a week over a steady state for a number of weeks had no evidence of infection. We don't know yet what the optimal amount is in a given week if it's less than 7 days. So current recommendations are 1 pill once a day. The question about, what was the second part? PrEP. Well, I did try to present that as the first slide where I showed post-exposure prophylaxis. Post-exposure prophylaxis, I don't feel comfortable using it with just 2 drugs, Truvada. I usually like to base it with a second class, depending on what the particular exposure of the HIV meds the person was on that you had contact with. But we do post-exposure 3 to 4 times a week at Whitman-Walker. It's commonly used.
Okay, thanks.
Hello, my name is Neil McKinney. I had a quick question about insurance because that was something that wasn't really talked about by the panel. Just because based on some of the research that little research I've done, I know that it varies. And thinking about communities of color and accessibility, that would be kind of my one concern that I would have loved to have heard the panel talk about.
So is the question, does insurance cover PrEP?
Well, I know that some insurances do, and it varies, but just your thoughts and your opinions about there's no standard to it, and knowing how that may affect particularly communities of color.
Well, I would just say this, that John Martin, who's the CEO of Gilead, made $185 million last year. And if Gilead were really extremely interested in a community service vis-a-vis PrEP, they would have a different color pill. It's going off patent in a couple of years because they've already made the umpteen $1 billion off of it. Okay. They would create another pill and they would charge 1/10 as much for it. Right now, we're talking about $10,000 the average cost. And so if 100,000 people go on it, that's $1 billion that goes right to the bottom line of Gilead. And let's be clear, the funding for most of the activities, not saying tonight, but most of the activities around PrEP is coming from being paid for by Gilead.
So just to answer directly the question, it's insurance companies, from what I've gathered from patients and individuals who have wanted to take PrEP, it is covered. It may require a prior authorization, which you can work with your pharmacist on. It usually takes 24 hours to get that moved through, as well as Gilead has a wonderful patient assistance program that most people are eligible for, and you can work through the program to have some type of copay for that.
Yeah, I think it's important to lift up, which is also a part of our challenge with the strategy itself, is that we actually have a law that says everybody's supposed to be getting access to the health care they need, right? It's called the Patient Protection and Affordable Care Act, in which some 20 plus states have refused to implement. I'm in one of those states. So the whole idea around where that coverage comes from will depend on what kind of coverage people have. So we want to make sure that all of our Medicaid directors are on board, that Medicaid is paying for it, which it is. And even if it's been denied, there's not been anyone who hasn't been able to get PrEP, to my knowledge, without an appeal. What we really have to do is educate the providers and educate the insurance counselors, as well as the folks within the agencies. Because I've had folks who've gone who could be covered, but someone in the healthcare setting told them that they couldn't get it because they weren't in a serodiscordant relationship. That's not what the guidelines say. Or is that because to a woman, you're not a bisexual or a gay man, you can't get PrEP. That's not in the guidelines. So what then turns out to I can't get my medicine covered is something else. And so we have to be able to discern between why people are not getting access and why they are. But as far as we know, there hasn't been an out and out denial of coverage of PrEP because the drug is already in the formulary.
Dr. Daniel.
Hey there. I'm Dan O'Neill. I'm a resident physician here at GW and a longtime member of the DC gay community. My question, one quick one, and that is, when the CDC moved from its interim guidance to its official guidance this past year, I've struggled to try to find what actually changed. Was it all expert opinion and we just, because of public pressure, moved to an official guideline, or what? Secondly, it's this notion of this idea that was brought up about the benefit of non-disclosure. And I would prescribe PrEP to a patient, but I do have some serious and valid concerns. And I do think it's disingenuous that we sit here and Michael Weinstein is singled out. And I find that many who have raised valid concerns, because the center of gravity on this issue has moved so much for PrEP, that we are silencing voices. And it's important that we have an open, free discussion. And I don't think that's happening. But to hone in on the question again, it's around the benefit of non-disclosure, as was mentioned, and what I feel is dangerous in that, because it does have the potential, PrEP does, to erode at a condom culture. I think it's flawed thinking to say condoms don't work, disclosure don't work. That's all we had for 3 decades. And I feel that PrEP has the potential to silence our discussions around disclosure and condom use. Daniel? Because why bother? So my question is, how do we avoid erosion if we're talking about erosion of condom use in the setting of PrEP?
Well, I'd like to respond, if I could. First of all, one of the most reckless acts in the history of public health was when the CDC changed its nomenclature from unprotected sex to condomless. That's happened within the last year, okay? There wasn't a lot of discussion about that, but I was flabbergasted, okay? I mean, we have 17,000 cases of syphilis. We had a syphilis elimination project in 2000, okay? Syphilis is exploding, and more than half of it is among gay men, okay? We have an incredible epidemic of chlamydia and gonorrhea. We have the prospect of the potential for a drug-resistant strain of gonorrhea, which hasn't hit the United States yet, but someday will. So I think that, you know, when you read on the blogosphere, you read in the Facebook posts, etc. Okay, I mean, PrEP is being portrayed as a get out of jail free card. And I just read something yesterday, a comment to an article in South Florida Gay News, which said, now I consider my partners HIV irrelevant. Okay, so I mean, I think that there is a blurring of the distinction between positive and negative. And this is not about demonizing at all, but it is the case that the person who is positive has a responsibility. And you can't simply say that it's every man for himself. And that's why I'm wearing, part of the reason why I'm wearing this t-shirt is we've been afraid in our community now for 30 years to say, stay negative. That that's somehow discriminatory. Well, I don't believe it is.
I've never been afraid to say stay negative, one. Two, I'm going to respond because the non-disclosure was a quote from me, and I want to be very clear that you hear what I say clearly. We're talking about PrEP. So people who use PrEP are HIV negative. So when I was talking about non-disclosure and the protection of non-disclosure for people who use PrEP, I'm talking about HIV negative people who right now, if I want to protect myself, it isn't every person, not just every man, it isn't every person for themselves, but it is every person's opportunity to be individually empowered to be responsible for him or herself without having to lay that burden or expect that burden to be carried by somebody else. Now, if somebody chooses to disclose, that's awesome. That is great because that's what being in a healthy relationship is about, right? But if you don't disclose, is it totally your responsibility for me to take care of myself? And if I want to protect myself, do I have to talk to you about that? If I have an option where I don't even have to disclose in that uncomfortable situation where, you know what, I think you're going to infect me, so I need you to wear this. Because that's how, at least the women that I work with, that's how they see every time they have to negotiate safer sex with somebody else. So in a situation where I don't have to negotiate that with anybody, with the exception of my insurance provider and my medical provider, but that's protected by law, right? That secret, that privacy is protected by law, then why shouldn't I have it? So the protection of non-disclosure is not just for people living with HIV, because I do have a big issue around criminalization. And why wouldn't a judge in 2016 look at a case in court and say, oh, well, I see you're HIV negative and you got so many tests. Did you consider PrEP? I mean, you know, there are different ways that we can hold ourselves responsible and accountable, but not in a world where I don't even have the tools to do that. And that's all I was talking about. Just wanting to be very clear. Nobody has said that condoms don't work up here. Nobody has said that we're peeling away the power of condoms. Nobody has said that. And not only that, I have heard nothing but a back and forth conversation. I have heard no silence.
Can I go on to the next question? All right. Look, we've got like less than 10 minutes. We got 5 to 10 minutes. So, I mean, I really want to try and get all of these questions. So if we can speed them, great.
And it goes back to this issue of 7 pills a week. Sorry, my question goes back to the issue of every day, every other day, 4 times a week, 2 times, that kind of thing like that. So in a world where in the studies so far, adherence has been varied, where federal dollars for prevention are not going up, they are going down. Side effects, though they may be rare.
What's the question, man? We got 5 minutes.
In a world where there are reasons why you might want to find out, want to explore the topic of should we spend this much money on it, or should we put this much in our bodies? Like, I want to know if anybody can tell me why it might be irresponsible to talk about 4 pills versus 7 pills versus 6 pills. Like in a world where, you know, there are reasons why you might want to go.
Well, if you promote 4 pills and people are non-adherent, then they're going to have 2 pills. Because you know, I plan on taking it on Monday, Wednesday, Friday, and Sunday. Oh, oops, I forgot on Wednesday, and then I'm gone. Then I've gone 4 days, and I've had unprotected sex, and then I'm infected.
Yeah, well, we live in an imperfect world, and people don't use condoms. Let me try and answer your question. The data we have is most robust for 7 days a week. So it depends on how much level of certainty you want before you make decisions for yourself. At some point, this is an individual making a decision. The role of a physician or anybody else is to give you tools to make informed decisions. The tools we have say that 7 days a week is the safest margin you have. There is data to show that if you were going to use PrEP, you would need to use it for at least 7 days before you would be protected. It would only be used in
The point is just that there are people who don't have access to drugs every day of the week. There are programs that have limited funds. I'm not saying that we should tell people they should only take the drug every other day or twice a week, but I'm asking, why is it irresponsible for medical professionals and people who are, you know, a part of this exploration to?
There's been no studies on 4 days a week.
There's an ongoing study right now on 4 days a week through the HPTN. When that study's completed, we'll be able to make a comment per your recommendations. Until then, we try to make.
But let me also say this. Okay, the cost of averting a single HIV infection under PrEP with the use of PrEP is more than $400,000.
Let's not get started with that, Michael. It's based on the prevalence in the community. The New York Times article showed that it was more cost-effective to do PrEP than to do Lipitor.
Okay.
So that's a complicated issue.
So let's not now like debate different drugs, different diseases, different treatment paradigms, different cities, different articles.
Okay.
All right. So, all right. I'm sorry. Your name, sir?
My name is Shane Johnson.
I know you, don't I?
You do know me.
Okay.
It's good to see you. So what I'm curious to know is that generally when we have these new strategies that come out for prevention, communities of color generally are on the back end of all this wonderful science and all of these debates that are happening. What I want to know is that does any data exist that demonstrates how PrEP is affecting communities of color, because we are disproportionately affected by HIV infection? And I don't need to know the exact numbers. The other thing that I want to know is how are public health communities marketing PrEP to communities of color? Because I mean, it's a successful tool. It's something that we can use. And I think that we need to do a better job of telling people that you have this entire buffet, a kitchen sink of options for prevention.
The lowest, they did a study just focused on MSM of color, and they had a 20% adherence rate in a study in which people were seen monthly and were tested monthly. So,
but so the question is, so what's the role of education in communities of color? And then what is there any information on efficacy within communities of color?
So I will say to the current information available, no. And if there is, please let me know where that is, because as a protocol member of the HPTN 073, to what I understand to be the only trial that's looking at open label Truvada in Black MSM in the country, which has taken about 2.5 years to be in development to get to the point where we are, there's no data available for communities of color.
Had to fight hard to get it.
Well, let's not talk about the fight. I'm still scarred from it, but absolutely. So, the second piece, when we're talking about having the conversation of how do we promote this to communities of color, we still, let's be very clear, as Black people, we have always, and you said it right, been in the back of the bus. We continue to be in the back of the bus when it comes to prevention strategies. So I would love to see campaigns that are driving sort of and fueling how do we talk to this or to communities of color, especially Black women and Black men, especially young Black men. Currently, I know of no initiatives that are doing that. I welcome the ability to work on any of those initiatives that come out of that, because I think that is critical. I know some jurisdictions are trying to move to that. They're looking at funding it from a local level, which is going to be really key to come out. But currently it is sort of still in existence or in development and in process.
My name's Patrick, and I'm in the Department of Prevention and Community Health here, and thank you all for being here tonight. My question is about the social and behavioral research being conducted among individuals taking PrEP, and if any research has looked at perceived response efficacy of PrEP and motivations to adhere in PrEP users.
There was recently a so that work is going on in qualitative assessments in patients who've completed the demonstration projects is one example of that, where there's been a lot of that, and it's let's talk later about it because it's complicated to summarize. I think the issue about risk compensation and risk perception is a very complex thing that's beyond the ken of when we have 8 people waiting to ask questions. So I'll wait till afterwards and then I can answer.
My name is Rami. I just have one comment and one question. I think actually PrEP and the other methods are a reaction to the failure of the condom culture. For one simple reason, condom is an unnatural tool, and you're involved in the most natural process that's out there. The second question is, as I thought of taking PrEP myself, but I have concern to strategies to face the explosion of the other diseases that's gonna be out there, if the people are doing unprotected sex, such as other STDs, how are you going to protect that? The second part of the question, would the PrEP as a medically have that chemicals inside your body? Would it, for example, the virus in the long term, would it, develop a resistance to the drug? And now, after 5-6 years of having people say negative, probably, the virus will modify itself and it would become, resistant to the drug. And how would the Truvada presence in the body or in the bloodstream, how would it affect the other drugs taken for chlamydia or syphilis or other diseases, and also for Hep C if somebody, got infected? Thank you.
We can talk about that tomorrow about 10 o'clock. No, just kidding. So first of all, the risk of mutations, though it's real and it's something we need to look out for, so far in the studies hasn't occurred very much. And the reason it hasn't occurred very much is, for the most part, people who've converted to being HIV positive are people who are not taking their medication, so that the virus is not replicating in the presence of drug. There will be people that happens for. There will be people that we don't capture the test. It is a known Achilles heel of the approach, and so it's something we have to watch very carefully when more people start to use it.
Well, if I can just say in that regard, also, is that there isn't a strict requirement that you be tested prior to being put on it. Okay, there's a drug.
That's factually.
Can I finish?
If you
can I finish?
Sure.
Okay.
I just let you.
Can I finish? Okay. No, I was on that one particular point. Accutane is a drug for acne. Okay, women who are going to take that drug, they have to show a negative test result to a pharmacist before they can get that medication because of the potential.
We're not doing
No. But no, the point. No, I'm getting there. Okay. You should. The FDA should require that a negative test result be shown to the pharmacist before PrEP is prescribed, because if you are already positive and you're taking it, which is a subclinical dose, because it's only 2 drugs and not 3, you're almost guaranteed over time that you will become resistant.
It was made very clear. I can't believe you're still making that point. It was made very clear at the advisory hearings when you raised that point, and people from AHF raised that point, that it was a distinction to be made between the provider who prescribed the medicine having that result of an HIV negative test versus the pharmacist having it before you get the receipt of the medication. It was felt that if the rule was put in place, that the pharmacist would have to have that rather than the provider having that, it would limit access. And because we're dealing with issues related to stigmatization and other things, it was decided not to do that. But it is factually inaccurate what you said, because it is essential that no one in the guidelines, the way it is written, that how Truvada would ever be given for PrEP, that an HIV test be done at the time before initiation, and not a home test, but either a blood test or a particular blood test that you use on a rapid test. And that testing be done on a repeated basis, at least every 3 months, and more if you think a person is at greater risk.
So we agree that a gold standard would be to have the pharmacist have a negative test result before prescribing.
No, I think
we would disagree on that point. Okay. In fact, what I'm saying is that it's important for the provider to establish the HIV negativity prior.
Okay, so
what is the protocol? I'm sorry. What is the protocol at AIDS Healthcare Foundation clinics for prescribing PrEP? I mean, there's.
I'll be happy to answer.
Well, within the clinics.
I'll be happy to.
There's a protocol.
We prescribe it.
But I don't want.
We prescribe it.
What I don't want to do is to do that, because I think that can open. That can open a can of worms that. I've got 1, 2, 3, 4, 5, 6, 7 people. I'd like to get out of here alive. I live here.
I just want. This was about transparency. That's it. That's all.
Okay. For once in my
life,
I'm
be
following
transparent.
the rules tonight. Yes.
I apologize, Tony, and to the questioners. I apologize, but I'm interested in transparency.
Okay.
Good evening. My name is Kevin. First, I want to thank all of you for being here. This is about the most open conversation I've had about PrEP outside of the conversation I've had with my partner on the subject. Speaking as someone who has been in a serodiscordant relationship, and speaking as someone who has not been a willing participant in all my sexual encounters, I just want to make one observation, and I will lead this into a question, and I'll preface this by saying that I mean this with as much possible respect as I can bestow upon my intellectual superiors here. I do think, and I have observed, that for those who are, say, anti-PrEP or not in favor of distributing PrEP, I do think that there is, some kind of silencing that's going on. I do think that for those who are not on this bandwagon, that by disagreeing with it, they are somehow being vilified. I also see and observe that for those who are anti-PrEP, they're not doing themselves a lot of favors when they make the case of PrEP being ineffective on the basis of individual choice. And the concerns that have been raised are valid in the sense of adherence, in the sense of toxicity. Those are valid concerns. But at the end of the day, all those concerns come right down to the individual choice. The individual has to get all the information that he or she needs and then can decide on that basis. So the question, and I mean this specifically for you, Mike, and I really appreciate that you've brought up an opposing point of view here, because I like when people disagree with me. That makes my world more interesting. But what you have brought up as an argument against PrEP, ultimately, every last one of them boils down to individual choice. And we understand that not everybody will make the right choice. But in the sense of, well, adherence isn't going to be perfect, so we shouldn't offer it. With due respect, that's the same kind of argument I heard from my Catholic priest in the sense of not using condoms. You talked about a condom culture, which I agree with. But the question that I have for you and for anybody who cares to answer is that if taking the individual choice out of it, and we've already acknowledged that toxicity is reasonably acceptable, and the point was brought up that it's really up to the individual, and taking the costs out of it, is there another significant reason to oppose PrEP that has not been brought up yet? Because as of now, again, respectfully, as a person who is, I mean, ideally,
I think I've got your point. It's a great question. First of all, let me make it really clear. The choice to use Truvada for prevention should be one strictly made between the patient and the doctor. Okay, physicians who treat high-risk negatives at AIDS Healthcare Foundation not only prescribe it, but are not restricted or guided in any way, shape, or form by the administration. But also, our sole objection, just to make it really clear, our sole objection to the promotion of PrEP and why we opposed the FDA's approval as an indication was because we felt that it failed as a public health strategy. Prior to the approval of PrEP by the FDA for prevention, every doctor in this country was free to prescribe it on an off-label basis to any patient. And let me say this also. First of all, I've spoken to some of the greatest minds in HIV who are much closer to my position. So I think what was said earlier about the silencing is very, very true. But I also want to say to what Terry Michael said, that I am old enough to remember when we popped penicillin before a night on the town, and that ended badly. But also, we were here in these kind of forums a number of years ago discussing serosorting as a way to HIV. That ended terribly. And so, you know, if I'm wrong about PrEP, I was skeptical about circumcision in Africa, and I was wrong, and I'm happy to admit it. If I'm wrong about PrEP, then I will be happy to say so, and I hope I'm wrong. I hope that all the people who are promoting it, including the CDC, will do the same.
Thank you.
Joe Izzo, I've been working in this field for 30 years as a behavioral health professional, and I'm old enough to remember when the Stop AIDS project started in San Francisco, and how it brought together groups of 8 to 12 men to talk about and discuss their feelings, the ways they could change behavior, the pressure that they could put kindly on each other to change behavior in a more loving and caring fashion. The sad news is there was no money for that. The money got pumped into drug companies. The end result is we're where we are right now with the failure of condom use, the failure of adherence to Truvada or any other drugs, because we haven't put the money into behavioral health change and learning how to motivate human beings for change behavior. That's the problem. My comment, I'd be happy to hear any reactions to that.
Well, I hate to comment on someone who I respect as much, who works in my own institution, but as someone who has a master's in counseling, I think there's been a lot of work on behavioral change. I've got a study in front of me here that was done in 2004, looked at 2,600 people, and behavioral change is incredibly important, but some people don't do it. Some people fail medical treatment. Some people fail psychological treatments. We need a variety of approaches because God didn't make us all the same.
You cannot advertise condoms on television, except in the wee hours of the morning. Our condom ads will not be run in any venue other than in Los Angeles. Two in Fort Lauderdale. Okay, you cannot promote homosexuality, the no homo provision. Okay, you have inferior sex education in virtually everywhere in the country, but particularly in the southern states. I mean, there are so many things we're doing so badly when it comes to sexual health that it doesn't necessarily mean that it answers the question of whether PrEP is good or not good. Okay, that's a different question. But the point about it is, let's not say that prevention failed. I mean, I think that hurts every community. If we say that prevention failed, we got to point the finger where it belongs, at religion, at government, at all the institutions who care more about their beliefs than they do about the sexual health of this country.
I absolutely agree. And what I want to echo with that, Michael, is we have not gotten past stigmatizing everything about sex except using it to sell everything else.
Anna? Hi, my name is Anna Forbes. I'm an independent consultant, and I have a question for Mr. Weinstein. I was very glad that you brought up first, do no harm, the importance of prioritizing ethics. I wonder what you would recommend for a woman who is not at all sure that her long-term partner is monogamous. In fact, she's fairly certain he's not. She's not sure that he's HIV negative. She can't afford to leave the relationship because she has no other way to feed her kids. She can't suggest condoms, either male or female condoms, without experiencing intimate partner violence. I wonder if you would agree that in her situation, having a conversation with her provider about PrEP that her provider would undoubtedly initiate would be appropriate. And I wonder if you agree with that, what you think are the ethical implications of the fact that an AIDS Healthcare Foundation ad may very well discourage her from ever raising this with her provider, and may in fact discourage her provider from considering prescribing PrEP to anyone, even if it's off-label. What would you say are the ethical implications of that?
Well, I think that it's perfectly appropriate for the doctor to raise the issue, or for the woman to raise the issue. Again, I go back to the fact that studies on adherence among women, you have to deal with the data. You cannot ignore the data. The data is such that it shows that.
Excuse me, Mr. Weinstein, we're talking about someone who has no protection. Condoms are not an alternative.
And I am saying, you want to ask me a question, or you want to argue with me?
My question was, do you take any ethical responsibility for the fact that your organization is putting out information that may very well discourage that person from getting the only
We're putting out the
alternative that's
facts
available?
about the studies that have been done. Okay, and I think that, first of all, that the advertising that we've done is predominantly, overwhelmingly been geared towards an MSM audience. But if there's an unintended consequence of the fact that you don't want to hear me, you just want a speech. So, I mean, you sat down and, okay. Okay. I said, you know, whenever you get into heated debates of this kind, there can be unintended consequences. And if one of the unintended consequences is that anyone goes without any form of protection that they could have, including Truvada, then yes, I feel badly about that. But I think that the potential for doing harm among MSM by saying that condoms are out the window and that you know, you don't have to worry about it, which is happening culturally, is a greater danger. And ethics do have to involve, you know, determining what the greatest risk is. And again, if I try not to be wrong in that respect, but I'll say to you that I've been in this for 28 years, and I've taken some very unpopular positions, which are now a consensus opinion throughout the public health community, including on testing babies and also in terms of the importance of names reporting. And I could go down a laundry list of others as well.
So you said, I just want to be sure I heard you correctly. You said that the benefit of getting the message that you're putting out to MSM is greater and of more ethical importance than getting a message to women.
I did not say that. Don't put words in my mouth. I did not say that.
All right, hang on. So, wait, Michael, I want to, because I mean, I almost heard a bit of what she heard. So I'm going to give you a minute to respond to it. Because I don't want to leave it there, right? Because I think what you were saying is that there's this great risk, particularly amongst your core belief, that men who have sex with men have disregarded this condom use. You want them to make sure that they increase their condom use. But I think what Anna is asking you is, and I want you can clarify, but I'm trying to get out of here too, again, still alive, right? Okay, because this is, I'm in between two forces now. So what I think Anna is saying to you is, hey, are you saying that responsibility to increase condom use amongst men who have sex with men is greater than your responsibility to that woman who has the potential to be in this domestically violent?
Absolutely not.
Okay, so what are you saying?
I'm saying that when we run an ad in the Washington Blade and in the San Francisco, I mean, in the South Florida Gay News, the audience we're speaking to is gay men. Okay, and so if you're referring to the ads, that's where they've been run. So it's not targeted to an audience of women. And what I said was, I'll try to be clear, is that if as a result of our advocacy, there's an unintended consequence that anybody who could benefit doesn't, then, you know, not only do I take responsibility for it, but I'm sorry that that happened. But what I think is that the much greater chance of what's happening is that that the condom culture in the community, far and away, overwhelmingly most affected, is under attack, and that has to be I have to use my voice to speak.
Right, we're gonna move on, because what I'm gonna ask you is that I'm gonna ask you a question. Okay, and I'm gonna ask.
I want to just add one. I want to say one scientific thing about the risk of the women, because I think it's important. The study that Partners PrEP, which did show a benefit, which different than the study that Michael mentioned, where the adherence ended the study, demonstrated very clearly the high rate of success. Yep. There are differences in the pharmacologic basis for PrEP in women than for men that are important to understand these differences. Because the comments we made earlier about the 4 days a week potentially be protective for men, it's not clear at all that that would apply to women. And so the issue about what would be effective prevention for women in terms of dosing and these levels is still being evaluated. So currently the FDA guidelines, which say daily use is recommended if a woman wants to use it, that's the only guideline that should be stuck to.
And now I'm going to go back to the ad question, because I think that that's a part that's still hanging out. Michael, would you be willing to have just a conversation with the women's group that does the PrEP, that call? Because I think they do a call, what, once a month?
Sure.
Every other month or something
About
like
every
that?
quarter.
Every quarter? And then that way you guys can have that conversation there, right?
Absolutely.
Okay, perfect. Then look at that, me.
If I came in, I think you could say that if I came into this situation with the headline that was here, that this was that I'm unafraid to brook opposition.
There you see.
Okay.
There you go. All right, who we got? I got one more over here.
My name's Tim Fitzsimmons. I've been working on an article for too many months now about PrEP. I've spoken to many people in this room, and I've even gone to your office, Mr. Weinstein, to try and find you in California. I spoke to one of your chief legal counsel. As far as I can observe, this is about an inflection point between the condom culture, as you described, and a possible erosion. If PrEP were adopted, say, by half of the recommended or estimated 500,000 gay men for 5 years, say the injectables don't happen, you mentioned you would support it. What do you think the situation would look like for gay men 5 years, 10 years down the line?
I think there would be a drastic increase in STD infections, and I think that there would be an increase in HIV infections among MSM, and I believe that there would be increased drug resistance.
All right, we got two more, and this is the last two.
My name's Tony Thomas, and I'm a medical case manager here in the city. And I want to address my question to Christopher, because you spoke a lot tonight about the broken healthcare system in the United States, and we know how broken it is. And I think about my own treatment regimen for blood pressure medicine, which I get readily free and available. I go right over to HF and pick it up. I take it every now and then. And I know, I know as a medical case manager about treatment adherence and the importance of taking my blood pressure medicine, but I don't always do it. And so I think about the patients that I work with and their prescribed ARVs and listening to the reasons for them not taking their medicines. And I think about the community, primarily the African-American MSM community, and in DC. What is a platform that we can create going forward from today as PrEP is in groundbreaking stages? If this is to be successful, how do we bring communities together to educate them about what is PrEP? Many of the people that I talk to have 9th grade educations. They can't read. They don't know how to take their medicines. They don't go to a doctor. How can we bring them together in a community forum to begin to address their needs that we as providers might be able to reach them to help them work through that?
Great question. So you're not alone. I don't take mine as well either, but that's okay. You know, it's okay. Melissa, don't judge me.
No, it's not.
No, it's not. But see, wait a minute.
Blood pressure.
Oh no, and you're judging me. You're judging me already.
No,
So
trying to keep you healthy.
We very great point. We're trying to keep people healthy. Imagine that. So I would start with saying Black Lives Matter. And if we could start at that basis, that Black Lives Matter, Black women, Black men, regardless of your sexual orientation, your gender, we do care as practitioners. I think the one novel thing about 073 that I'm very excited about is that it has a piece that looks at the sort of psychosocial pieces that are involved with the men taking drugs. So we're not just saying, come take this pill, let's dangle it, let's, you know, increase condom uses. It's, well, you have an option of taking this pill. This pill could do this. Here are the data facts. You make a choice whether or not you want to take this. But what else we're going to deal with is really sort of, do you have employment? Do you have a job? Do you have a way to get to the doctor that you're looking for? As we begin to roll men off of the study, do you want to go have a conversation with your doctor? Let's talk about what does that conversation look like? Men have never had conversations about sexual reproductive, Black men have never really had conversations about their sexual habits with providers because of the fear of judgment. So to sit here and say, I skipped a few doses of my hypertension medicine and to sort of see that, yes, it's coming from a caring space, but is that the delivery in which we've really put that? So I think as we begin to look at new and shifting the paradigm, it's really important for us to become vulnerable to change. And as practitioners, we want to continue to do the way that we have always done it and say, well, they just have to conform to us. And, you know, we can't imagine communities of color to have large town forums like this. And as Tony pointed out, this is not a face of the epidemic. I love everyone for coming and welcome to GW. DC again, but this is not the epidemic in DC. So how do we begin to move outside of the 4 beautiful walls that we have here, put on some jeans and a sweatshirt, and go have a conversation with grandma and grandpa about really, you're having sex. Let me give you some options of doing this. Do you know how to put on a condom? What else do you have going on in your life that may or may not hinder you from taking a drug every single day? And until we do interventions that really focus on the systematic issues and the systematic breakdown, we'll continue to have those issues within this community.
And when can we begin those conversations?
So I have started those conversations. I've went across the country in jeans and sweatshirts and swimming trunks. And if you invite me to come, yeah, it was a swim party in LA. But you know, I am not afraid to have those conversations. And I think it goes to cultural competency. And I think that's, you know, a really blanketed statement, but it's really cultural responsiveness on our part.
Can you give him your contact information,
Absolutely.
particularly about some of the like kind of work groupy stuff that you're doing,
Yes.
the group stuff, and so maybe he can get involved in that level too.
What, just one sentence, and what I think it might be a run-on, but what I think that you pointed to, especially in our communities, which is also a part that we've been working on, is taking the exceptionalism out of HIV for our communities and for our families. When we can talk about hypertension, diabetes, obesity, HIV, STDs, and smoking in the same room, it diminishes the stigma around HIV, and it also, because everybody dealing with any one of those disease states has issues with adherence. So we can talk about it in a much more comprehensive and inclusive way that doesn't exceptionalize HIVs, because their stigmas are still there in our community.
Let me make a final point about one important minority, people who want to talk about sex. So in general, white people, black people, yellow people, brown people don't talk about sex. We talk more about sex today than most people talk the rest of the week. So providers and patients don't want to deal on this territory. And so we need to open up that dialogue for everybody.
Thank you. All right. Last but not least, give it to us, baby.
Hi, my name is Will Martin. I'm a first-year public health student here. My question is for all of you. As professionals in the public health field, have you seen, just in general, this discussion has mostly been either about Truvada or against it, et cetera, but have you seen, as a group over the years, an increase in the using both all behavioral, epidemiologic, biological, et cetera, means? Have you seen an improvement in the HIV/AIDS community, the STI, the community of STIs, other minorities, et cetera? Have you seen an improvement, and do you think there will continue to be improvement, or do you feel like that we've just hit a point where it's going to go one way or the other?
The biggest improvement.
Paper, scissors, rock. Paper, scissors, rock.
We'll do a two-part, all right? The biggest improvement was seen in the early 80s in San Francisco when people were dying. When people were dying, everybody changed their behavior. And so STD rates plummeted during that period. And if there was a behavioral intervention that caused a rapid change in public health, it was watching people suffer. Now that we're in a different time of the epidemic, those efforts are in a very, very different phase. It doesn't mean that it's not incredibly important, but you know, we can argue whether we plateaued that benefit. So I think that because we're in a certain sense, we're a victim of our own success, because HIV has become a treatable condition, and treatable is not to say that it's a good thing, but it's become a treatable disease. The impact on prevention and people's laxity around being anxious and fearful of getting HIV positive has changed.
Well, I would just say that we're not going to put the genie back in the bottle. You know, people have multiple sexual partners. And sexual hygiene just has to be a standard part of the procedure. You know, you go to the gym, you take vitamins, you get a checkup. You know, it's just got to be that way. And I just think that if we don't have a vigorous campaign around STDs, even separate and apart from HIV, we're going to see an explosion even beyond what we see now. And I think it's very, very critical that even if people don't want to talk about it, that we get policymakers to address it. I mean, to go from almost no syphilis to 17,000 cases, you know, where is that going to be in 5 years? That's going to be, you know, in the 6 digits if we let it go.
So I want you to have the last word, Chauncey. So Rick stole another phrase out of my head, and I was going to say the same thing in terms of us being victims of our own success, but with a different angle. And I'm sort of, giving it a loose generalization, but what I have seen change, which we still have to work around now, is that for the first, and I've been in it 30 years almost now, and I'd say the first 20 plus 25 years, well, let's say a good 20 years of the epidemic, community, just for the same reasons that Rick and Michael as well have talked about, community was out front. Community drove everything. Community drove the science, drove the policy, drove how the funding got happened. We're still sitting here fighting for Ryan White. So community was consistently out front in every sphere, bringing researchers, scientists, policymakers, and decision makers along. At some point, the trajectory changed. Science sped up. Policy got ahead of us. And to some degree, that was a success, that we got folks in the leadership and the decision to get where we needed to go. But then community has fallen behind. And so by falling behind, we're not staying in front on those real stories, on the advocacy and on the activism to keep things going, to talk about I'll give you an example. Just within NIH, we're struggling on the real meaningful intersection and integration of behavioral and social sciences in clinical trials. This is a big issue that we're all struggling with at the community level, but also in the scientific community. Is the community there struggling with us through it? Not yet. So we've got to catch back up to ourselves and not necessarily get out in front, but now we need to all be moving in tandem because we've got more to move with.
And I think you can clap for that. I really think we're talking about privilege. And we're negating and mitigating sort of the privilege we have as advocates, as practitioners, and those who are very well informed of what's out there. And one thing to my friends, I talk about sex all the time. It's just, I think if you don't do it, you should talk about it. So in that space, you really have to have those conversations and be very transparent with those conversations. I'm not married. Sadly. But so I think we have to understand the privilege and how privilege has influenced sort of our reaction. And we've become very reactive as a community of advocates instead of being proactive, which is where we used to be. And so how do we begin to translate that conversation, as Dazon was saying, from really being reactionary to being proactive as we move forward, especially with new tools and understanding the whole comprehensive approach.
Thank you very much, Chauncey. Thank you. So again, I'd like to thank everyone for coming tonight. And as I said when I began, the 4 people that are on this panel tonight, you don't have to agree with them. You don't have to kind of follow, their train of thought, but they are in fact thought leaders, not just in the United States, not just in the district, but around the globe. And we are truly honored to have them here to share their experience with us. So again, I would like to thank each and every one of you.
Okay.
And again, thank you, Tony, for a great moderation tonight, and to our panel. As you all know, Whitman-Walker Health has a commitment to culturally sensitive, affirming, and quality healthcare, and we hope that we've provided some incredible information tonight to help you make the best decisions for you. If there's anything more that you'd like to hear on this topic or any other topics, this was the brainchild of Sean, Jane, and Justin Goforth. Don't forget to leave your comment cards out front. We hear you, and we look forward to seeing you at our next forum. Our CEO, Don Blanchard, will say goodnight. Thank you again for attending, and have a great evening.
Thank you. It's great that you came out tonight and listened to what was a really informative discussion. And one of the things that's a hallmark of our place, and that I think is the hallmark of discourse, is dignity and respect. And whether you agree or disagree with any of the panel's views, hey, listen, I'm not responsible for paying the bills here. That's somebody else's gig. I got that on a day job. I really mean this. Tonight's panel was done with a lot of dignity and respect, as was your participation as an audience. And I wish we could replicate this, quite frankly, in communities across the country, because this discussion has to go on. And the hallmark that happens at Whitman-Walker, as well as other places that are serving communities of color who are fighting HIV or other disparities in the healthcare system or in community, is really this notion of getting people information, empowering them to make choices, and then having informed discussion with the people in their life, including their partners and their practitioners and their family members. And when we don't have that sharing of information, we get into trouble. And that's what I thought was wonderful about tonight. Again, hats off to George Washington University and the Milken Institute for hosting. Hats off to Tony Young for moderating. Our panelists were great. Michael, thank you for being here. It's never great to come in when you think the playing field's slanted. I will tell you personally, what I was worried about a Daily Show episode with that Washington football team thing that went on the last few months. I was afraid that Michael or anyone else associated with AHF might feel that way. We never set it up that way. We wouldn't do that. We have too much respect to you and your organization. We are partners in the fight against HIV here locally and across the globe. So thank you for being here. Hey, don't forget, our next big event is the Walk on October 25th. There's cards out front. There's Whitman-Walker team members here. I hope to see you all Saturday morning on the 25th. Thank you.